according to my time here, I'm seeing 2:59. So that gives me enough time to introduce you, although I don't think you need an introduction. You've been very involved in faculty activity. And appreciative, Professor Trotman. This is Helen Trotman-Edwards, right?
Yes, yes.
Who has really worked very hard with the ethics committee. I mean, I was with it in the earlier days, and under your stewardship, Prof, we are really appreciative of how organized the committee is now. And in terms of the turnover, it really has really improved. And so I look forward to your presentation today. I know you're very meticulous about ensuring that we cross our T's and dot our I's. And so I am glad that you're able to give time today. So with that, we are expecting large numbers. We had over 70 participants registered. So I think they will be coming in soon. We're not now up to 15. But please, Professor Trotman, welcome again. Thank everyone for attending. And one thing about the Zoom platform, it doesn't give us a chance to do, a little round of applause, but perhaps we can get everybody to just maybe put the little sign in to get her started. And with that, Prof, hand over to you.
Okay, so the first thing I would like, because we do have persons who, oh, why did it go away? We do have persons who submit and they are not aware of our, right. So this is the website that we go to, the Mona Campus Research Ethics Committee. I just want to show persons where you find the research proposal toolkit that I will be speaking to and guiding you to. So all researchers prior to submitting, I think, should go to the research proposal toolkit. I'm not going to, go to it, but it has the guidelines for preparing and a lot of resources. So I will invite persons to go there prior to submitting. Also, we have here on this link, I'm not going to go to it, but the Mona Campus Research Ethics online submission video. So that walks you through how to submit online. The other thing is that we have our schedules. If you click here, don't know why it's right. You will see meeting schedules. You'll see download the 2025 schedule. If you click, right, here it is, they'll give you the dates, right? So we are in March. The meeting date of March 7th went already. So the next meeting is April 4th. So if you had wanted to catch that meeting, you should have submitted by March 10th, which is gone, right? And so you can look and see which month you want to make and by which you are going to have to submit. So I just wanted to alert people that the website has a lot of information. Here you'll have forms, different forms that you can go to. Informed consent guidelines, assent guidelines, right? Guidelines. So please, prior to submitting, go and make sure that your proposal meets the guidelines. Now I'm going to stop sharing to then go to my PowerPoint. Okay, so today we're going to look at key steps to secure research approval and really pitfalls that researchers may get into. Now, I always start with this slide because, why research oversight? Some researchers think, we can self-monitor, but I mean, this is something that happened a long time ago, but would not happen in today's world. So as you see here, Edward Jenner, who is really the father of immunology, right? In 1796, he noticed that milkmaids who grow cowpox were protected from smallpox. So what did he do? He said, that's very useful. So he took some material from a cowpox sore, he inoculated it into the arm of a 9-year-old, his gardener's son. He had children, mind you, but his gardener's son. And the child was subsequently exposed multiple times to the smallpox vaccine. And he never got smallpox. And from that, we developed the smallpox vaccine, and the human race is protected. But as you can see, there are several ethical concerns, and something like this would not happen in today. Okay, so what are the steps? Step 1, preparation of your proposal with oversight by the supervisor. That's the first step of submitting. That supervisor oversight to make sure that your proposal, is done in the proper way. Then what we recommend, some departments have it, but it would be useful if all departments had a research meeting where the proposal will go to that for internal review, because there are a lot of researchers in the different departments that can give guidance. So we are saying this internal review should happen first. Then step 2, you visit the website, which I just showed you, because on the website, there are a lot of guidelines. So once again, you go through your proposal, you make sure it's meeting those guidelines. There are then internal checks at the level of the supervisor. That's step 3. And then step 4 is then you now reach the ethics committee. And step 1, 2, and 3 are very important, because if you're waiting for some of those things to be done when it reaches the committee, then it delays your ethical approval. So just quickly, what is the ethical review committee? Or as you know, we are the Mona Campus Research Ethics Committee. So it's really a committee that is established independently to review, approve, and monitor research involving human subjects. And really and truly, it is responsible for safeguarding the rights, safety, and well-being of research participants. Right? So that is the role of the committee. We are looking to safeguard the research participants. But you would also recognize that in doing so, we are also safeguarding the researchers. Right? So this protects researchers from potential conflicts between the pursuit of science and the welfare of research participants. What is research? Research is a systematic investigation designed to develop or contribute to generalizable knowledge. Now, I want all clinicians and students in the clinical sphere to recognize that research is separate from what is your responsibility as a clinician. As a clinician, the individual patient is your concern, whereas research is really to contribute to generalizable knowledge. What are human subjects? Individuals about whom an investigator obtains data through intervention or interaction with the individual, or identifiable private information. Okay, so what is the role, as we say? So the role of the Ethics Committee, assessment and evaluation of research. We also should be monitoring, which is an ongoing process of continual oversight, re-evaluation of ongoing research. As it is now, our resources don't allow us to monitor as well as we are supposed to, and we do depend on our researchers to self-monitor and to report to us when there are adverse events, right? But we do monitor. Now, suspension or termination of research not being conducted in accordance with ethical guidelines. The Research Ethics Committee does not have the authority to sanction researchers. However, we do have the authority to report it. So in terms of on campus, this will be reported to the campus registrar's office, right? And then the disciplinary procedures that are outlined by the university. So the university will be the person to sanction, not the Research Ethics Committee. And of course, we have a role in education. So just generally, when you send in your research proposals, we are guided by 3 basic ethical principles, which is the basis of oversight. Respect for persons, right? That is, persons must be treated as autonomous agents. And persons with diminished autonomy, such as children, pregnant women, prisoners, mentally incapacitated, must be protected. And those are the ones we are also going to look at in terms of protecting. So, what is the practical application of respect for persons? It's the informed consent process. And I'm going to come back to that because informed consent is a process. It begins from the beginning of your study and it is ongoing throughout the conduct of the study. It is not just merely signing, the study participants signing a form. So persons to the degree that they are capable should be allowed to self-determine what should or should not happen to themselves. And so this opportunity is provided when there is true, what we call true informed consent, which has three components: information that the researchers are going to give, comprehension, and voluntariness. And the second principle is beneficent, which non-maleficence, which embodies minimizing risk and maximizing possible benefits for study participants. So these are the things we are looking for. And assessments of risk versus potential benefits must aim to prevent study participants from being exposed to undue risk, which outweighs the possible benefits to be accrued from participation in the study. The third principle is justice, and this ensures that risks and benefits are equally distributed throughout the population. The practical application of justice is fair selection of your study participants. So study participants must not be chosen because of easy availability, diminished autonomy, or social bias. And that is where your inclusion, exclusion criteria come in. Now, a lot of persons, when they send in their proposals, we have heard persons saying the ethics committee is only supposed to deal with ethics. Why are they looking at scientific value and validity? That is not an ethical concern. However, I would draw researchers that all proposals to conduct research involving human subjects must be submitted for review of their scientific merit and ethical acceptability. And this is coming from the Council of International Organizations of Medical Sciences, which are called CIOMS, from their guidelines, right? Now, scientific review and ethical review cannot be separated because scientifically unsound research involving humans as subjects is ipso facto unethical in that it may expose study participants to risk or inconvenience to no purpose, even if there's no risk of injury. If your proposal is not scientifically sound, then you're doing research that cannot yield reliable and valid results. And therefore, you're putting study participants at risk with no hope of any benefit. So for those, we do look at scientific value and validity. What is value? So is there a need for the research? Sometimes we have gotten research proposals where, based on the literature review and how the researchers are speaking, there is no doubt in their mind that this intervention is is the best for as we have it now. Now, if there's no equipoise, so equipoise is that we truly do not know which, if you have two intervention, which one is better than the other, right? There must be equipoise. If there is, from the literature review, there's no doubt in our minds that this is a valuable intervention, then repeating the study may not make sense. Because why are you now going to withhold an intervention that is known to be beneficial from a group of study participants just to reprove whether or not it is if it's beneficial? So we look at that. Is there a need for the research? Does the research address an important problem? Will the research add to the general fund of knowledge? And can the results be translated to practical application? And what are the possible health, or economic benefits. So when your proposal comes to us, we are looking at that. And what gives us that information is the literature review. And so I'm going to come to the literature review. Sometimes persons send in proposal with a very abbreviated, limited literature review. And really and truly, if you do that, then the reviewers cannot determine, the scientific validity about what you want to do, right? So we do look at your literature review. It's not that you send it and when we are reviewing, we don't look at it. Yes, we look at it because that's what's going to put your research into context, right? So we look at the title because sometimes we have a title and you say, oh, okay, I understand this. This is what the study is about. And then when you read the methods, when you read the procedures, it's not congruent. So the first thing we look at is the title congruent with the contents of the study. Has the study been placed in context? So have you reviewed the literature? And remember, review of the literature is not only to give us studies that agree with your point of view, but ones that disagree. We must have the full gamut of what's in the literature. So has the study been placed in context? Has the relevant literature in international and local, has that been reviewed? Has the literature review focused on the topic as a basis for the research? So sometimes we have a beautiful literature review, but it is not focused on what so for instance, you may be studying the effects of, and I'm just throwing this out, say measles vaccine, but you give me a whole literature review on immunization and very little on the measles vaccine and other studies about the measles vaccine. So sometimes there's a beautiful literature review, but it's not focused on the topic. Has the researcher exposed both corresponding, as we said before, and contradictory viewpoints on the topic? Is there really equipoise? Is it that we really don't know, and therefore this research is going to add to that fund of knowledge? Has the researcher justified the need for the research? Is there a clear rationale? If applicable, is the hypothesis explicitly stated? So we do look for that in terms of determining scientific validity. Then we move on to, and I'm just following as you would notice, you would submit on the online, right? So we look at the aim and objectives. So is there a clear research question? Sometimes we get a proposal and sometimes there isn't an aim. We just see objectives, or there's no clear research question. So you need to make sure that, because the truth of the matter is your research question is the basis of your study. So if you don't have a clear research question, if you don't know exactly what you're doing, then your proposal is all wibbly wobbly and reviewers can't make sense of it, right? Are the objectives congruent with the aim? Because the objectives are steps that lead to achieving the aim. Sometimes you'll get a proposal where the objectives is bigger than the aim. An objective cannot be bigger than the aim because the objective are the steps you are taking to achieve the aim. We look to see that your objectives are SMART. Are they specific? Are they measurable, attainable, realistic, time-bound? A lot of times, researchers will have objectives, and then when we go to the methods, there's no method that speaks or that directly correlates with that objective. So as written, the objective cannot be achieved, right? Are the variables clearly described? In terms of the methods, right? So we've gone through literature review, background, aim and objectives. Now the methods now, you are telling the reviewers exactly how you're going to do and achieve your aim and objectives. So the study design, right? What is the type of study and the scientific approach clearly defined and appropriate. So we do look at what you state your study design is. We look to see if the objectives can be achieved using the stated methods. Now, just to say, sometimes with the methods, people do not systematically go through the methods. So what we mean by that, when you put it down, I am supposed to be able to read it and understand. So a study participant, what are the procedures that will happen? And it's in sequential order, right? And it is clearly summarized so we can follow. We can follow. And I think a lot of times we have a problem with that. And I'm going to come to it, but we have a problem with recruitment. We have a problem with the informed consent process. So people are not clear about the recruitment. We hear that patients are going to be recruited from the medical clinic. And then from there, we go on now to here, blood samples will be whatever. No, no. Who is going to sensitize those patients to the study, right? So first of all, there's sensitization. How are they going to know about the study? Are you going to place flyers in the clinic? Is it that you're going to go to the clinic and in the general waiting area where they're waiting, the researchers will speak to the persons who are sitting there, tell them a little bit about the study, and then persons who are interested will go to the researchers in a private and confidential room. What is going to be happening? How are you first going to approach your potential study participants, right? How are you going to sensitize them about their study? And then where, after that now, where things like the informed consent process going to take place, etc. And we do sometimes have a lot of problem with that. I'll come back to it as we go forward. So we look at, based on your methods, can the objectives be achieved? Are the methods described in sufficient detail? Is the measurement of all the study variables and outcome variables described? Have confounding factors been addressed? And are the measurement methods valid? We look at how you say you're going to do your sampling. How are you going to get your sample? So again, is the study population clearly defined? And sometimes persons will say they will be getting study participants from 4 hospitals across Jamaica. That is not good enough. We need to know which hospitals you're going to, right? So is the study population clearly defined? Is the sample subset of study population in which the study will be conducted? Is the sampling method appropriate for the study? So we look at sampling method, and we look at what technique will be used. So is it going to be random? Is it systematic? Whatever you have explained, is it appropriate? And again, we look at the sample size. So sometimes persons will give us a sample size and give us no idea whatsoever of how they came to determining that sample size. So we look at, has a sample size calculation be performed where relevant, and I say where relevant, and what are the assumptions for determination of that sample size? We then go on to look at your instruments. Is there a standardized research instrument available that you're going to be using? If so, is it in the public domain? If it's not in the public domain, has the relevant permission been obtained? If it is a new instrument that's going to be introduced into a different setting, right? Is it going to be pre-tested, right, to see whether it is, valid for the population that you're going to use it in? Are there skilled personnel available to perform data collection, or will they be trained? How are you going to deal with, intra and inter-observer differences and biases? Is the necessary equipment available? Are the necessary research facilities available? So these are the things that we want to see in your proposal. And then how will the data be collected? How would measurements be conducted and by whom? As I said before, measures taken to limit inter-observer and intra-observer error. What instruments will be utilized? And in terms of scientific validity, reliability, how repeatable, your findings are going to be, right? And whether there's internal or external. So internal validity, will the instrument or procedures measure what they're supposed to? So sometimes persons send a proposal and said, these are the procedures, but we can't see, using these procedures, how are you going to obtain your aim and objectives? And can the results be generalized beyond the study? And sometimes it cannot be. And in your limitations, you need to include that. And as we said before, for data to be valid, they must be reliable. So invalid results. Why do we go through this? Because invalid results can harm future patients, can lead to inaccurate policies and protocols, can waste money and resources. We look at implementation. So in your methods, in there you'd see implementation. So do the researchers possess or have access to the necessary expertise to conduct the study? So sometimes you will have researchers send in a proposal and clearly they need somebody with, say, neurological expertise, but we are not seeing that person on the team, right? Can the research be practically implemented? So again, I'm coming to procedures. Recruitment, I would say to you that a lot of our problems are recruitment. And why do we have problems? It's difficult for clinicians to separate being a clinician and being a researcher. And that's where we have this sort of conflict and where we can see problems. So let me give you an example. As a clinician, I can go to a patient's docket, get their phone number, and contact them because there's some clinical complication or some result that I have to communicate to the patient. So as a clinician, right, and what we have to remember is that we have a new data protection policy and we should be aware of it. And the hospital is governed by it. And remember, there's something that's called privacy and confidentiality. So if I am at home and a physician calls me and say, you know, you were admitted and so, you did these blood tests, we have gotten the results, we'd like you to come in to discuss it or whatever, that is fine. Because again, as a clinician, my primary responsibility is to the patient and the patient welfare. It is certainly a different thing for me to be at home and a researcher calls me and say, I am contacting you because 2 months ago you had an operation for X, Y, and Z, and we are looking at patients. That's not appropriate. How did the researcher get my name, get my number, know that I had a procedure done at the university hospital? That's a breach of privacy and confidentiality. And many times in a proposal, we'd see researchers saying they will contact potential study participants. They will go to their notes, get their contact number, and contact them. So again, we see this time and time again. Or we will go to the clinic daily admission register, and we will look for the patients who have registered because they're coming because of diabetes, and then we will approach those patients. A researcher cannot do that, right? You cannot access patients' information until that study participant has given you consent to do so. So we have a lot of problems with recruitment because, again, clinicians cannot separate the two. Being a clinician and being a researcher, what you're entitled to do as a clinician versus what you're entitled to do. We also, sometimes persons say, well, we don't have a research assistant or whatever. I'm the only doctor in the clinic, so I need to recruit and consent study participants. No, we cannot have that because remember, that's a power relationship there. And there may be undue influence. You are the doctors looking after the patient. They may not have the agency to say, no, I don't want to be in your research. And therefore, we say no member of the health management team of a patient should recruit or consent their own patients, right? So the recruitment, we need it stated clearly. Where is it going to happen? When? How? And by whom? And a lot of times that is missing. We'll hear where, but we're not hearing when, we're not hearing how, we're not hearing who. by whom? Certainly, we are not going to allow you to recruit a patient on the morning of operation. So the anesthetist, we have had things like that. You know, people saying the anesthetist who is dealing with the patient, you know, will, you know, sensitize them and consent them. No, this is the anesthetist who's going to be looking after that patient. When at my pre-op, you know, thing with the anesthetist, I don't have the agencies to say no, because I'll be thinking if I say no, what may happen, right? So where, when, how, and by whom. Informed consent process. Again, we have a problem with that. Again, where, when, how, and by whom. I will come to that a little later. So we need to have sequential flow of research activities and interventions. And for clinical trials, which I'm not going into in any great detail, but they are the spirit guidelines. So if you're doing a clinical trial, spirit guidelines, data management, I'll come to that. And we look at all of these things. So we look at the procedures, the recruitment, the informed consent. What are the research activities? And sometimes there is study participant burden, because researchers may want to do multiple interventions, multiple things at each visit. So we look at that, and if we think there's participant burden, we are going to tell you are trying to do too many things at one time. We look at your data management, and we do the researchers have an adequate budget? What are the proposed methods for analysis described in sufficient detail, and are the proposed methods of analysis appropriate for the study? And I would say that if you do not have expertise in statistical analysis, getting a statistician or somebody who has that expertise on your proposal from the word go, so that you can be guided when you're writing up about your data analysis. And we also look at, do the researchers state proposed methods of this dissemination of the results of the study? We have had a proposal already where the researchers said they don't intend to publish. And we are like, well, if you do not intend to publish, how are you going to add to the fund of knowledge? And why are you doing the research? Because remember, the basis of research is to add to the fund of knowledge. So if you're not going to publish, I mean, I don't know if it was a slip, but we have had that. So what are the common problems? The study design is inappropriate for the research question, and based on that, the researchers are not going to be able to attain their objectives or their aim. So there may be poor study design. A lot of times, the procedures are deficient. So people do not give us that step-by-step systematic, what is going to be done? What are the procedures? So a lot of times you have to send it back and say, please expand on your procedures. Sometimes there's an inadequate sample size, or sample size hasn't been calculated. And sometimes the measurement methods lack reliability or validity. So these are some of the common problems. And when we see it, the researcher get comments. Okay, so just the informed consent. Now, I know some persons say, oh, they are so picky about the informed consent form. They are so picky. But you have to remember that the informed consent form, right, is like a contract. And therefore, what is written there must be clear, transparent, and the potential research participants must be able to understand. We say that the informed consent form should be written at the level of a grade 8, right? It doesn't matter where you're doing it. It doesn't matter that you're doing it on the campus. It must be written at the level of grade 8. Now, remember, there are two different things. There's the informed consent process and the informed consent form. The form is just documenting that the process has been done. And I think a lot of times we would see researchers say, oh, they will give, when we talk about the informed consent form, they say the study participant will be handed a form to sign. That is not informed consent, right? Informed consent is a decision to participate in research made by a competent individual who has received the necessary information, has adequately understood the information, and after considering the information, has arrived at a decision without having been subjected to coercion, undue influence, inducement, or intimidation. So informed consent is a process, not just the signing of a document. It begins with the first contact with a prospective participant and continues throughout the course of the study until the study ends. The signature of the participant does not validate the informed consent process. It is the quality of the interaction between researcher and participant that validates the process. A signed form is just documentation that the informed consent process has taken place. So handing a prospective participant a form to read and then ask questions if necessary is not informed consent. We have to remember that some individuals are limited in capacity to give adequate informed consent, such as young children, adults with mental or behavioral disorders, and persons unfamiliar with medical concepts and technology. So, as we said, the informed consent process, voluntariness, who is when we look at, is there a power relationship? Is there undue influence? Can the patients be conflating research procedures with therapeutic procedures, which means therapeutic misconception? Where are you going to conduct this informed consent process? It needs to be where there's privacy and confidentiality. It should not be sitting on the bench in the clinic with other patients around that you are going to be doing your informed consent process. When is it going to be done? It should be done, and the study participants should be given adequate time to consider participation. And sometimes that means consulting with family members as to whether they should participate or not. Now, clearly, depending on the research, right, the level of that is going to be different. Clearly, I don't expect, so for instance, a cross-sectional survey that may be looking at satisfaction with clinic procedures or something, clearly the time needed for that is different from the time needed for a clinical trial, where you may be given experimental intervention, right? So we do look at the type of, so a cross-sectional survey that, is dealing with satisfaction or so. Clearly somebody can decide, yes, I would like to do it, and then proceed to do the survey. And that's different from when you have interventions like a clinical trial or interventions where they may have to come back multiple times, when blood needs to be drawn, samples taken, etc. Right? But we do look at that. Is there adequate time to consider participation? And we do look at how you're going to do that informed consent process to make sure there's no coercion, no inducement. And of course, part of that, on the informed consent form, there must be enough information, right? So there should be the purpose. Why are you doing the study? Why am I being invited to do the study? So, it should be clear. You are being invited to take part in the study because you are attending the medical clinic at the University Hospital of the West Indies, and we are doing a survey at this, whatever. So what is the purpose? Remember, if it is student work and it's being done in fulfillment of a degree, that should be clearly stated. The potential study participants should be aware, for instance, if it's something experimental, that differs from medical care, right? They need to know who is doing the research, what are the affiliations or collaborators, why is the research being done, what are the objectives of the research, and whether IRB approval has been obtained. In terms of the procedures, it should be clear who is eligible, what are the eligibility criteria. They should be clear about what are the tasks to be done and the time commitment for those tasks. So what is expected of the study participant, the frequency of procedures. For anything, if there's randomization, if there's blinding, that needs to be explained to them. Random, if random, it's like flipping a coin. Blinded, you're not going to know in which arm. So you may be getting the experimental drug as well as you may not. right? Estimate of time of commitment, number of visits. Is there going to be any monetary cost to participation? They need to know the risk, right? Here again is another pitfall because for some reasons, persons believe that, psychological risk, they do not pick up psychological risk. So we would have maybe a study that is looking at interpersonal violence. Or let's not even go there because that's clear. Say we have a study looking at teenage pregnancy and whether the teenage mothers after delivering go back to school. And we'll have a researcher that says to us, this is minimal risk. Now, remember, this is a teenage pregnancy. We do not know how this teenager may have been consensual, it may have been non-consensual, whatever. Not because you are looking at whether she goes back to school or not, which you believe, is minimal risk, means that when you start to ask her questions, you're not going to stir up feelings, right? That has psychological distress. So what we find a lot of times, researchers don't seem to be able to identify when what they're doing, a procedure they're doing, may precipitate psychological distress in their study participants. So this is something you have to look at. Don't just say this is no more than minimal risk and you're not really looking. Look at your questions. Look at what you're asking. Is this going to stir up So a lot of times the magnitude of the risk is underestimated, right? So what's the magnitude? Are there any inconvenience, any risk of breaches in confidentiality, any adverse events, and what are the probability of it happening? So there's nothing with you saying that, there's a possible risk of breaching confidentiality. However, we believe the probability of this happening to be very low because these are the things we are doing to mitigate against it. Right? Potential benefits. There are benefits to the individual, there are benefits to the society, right? They must be realistic, not overstated, right? And we like to say may. You'd see sometimes you get back a comment, please change will to may. So someone will send it in and say the results of this study will change government policy on the way we deal with teenage pregnancy. No, it may, because you don't even know the results. Right? So a lot of these positive, it will do this and it will do that. You may change it to it may, right? It could, we hope. But this definitive it will, right? Please try to avoid that. And if there are no benefits, clearly state no benefits. Compensation and reimbursement, right? Now, let me say, people mix up compensation with benefits. So they say the benefit is that they're going to get a $500 phone card. Compensation and reimbursement is not a benefit, right? You're compensating or reimbursing for time, transport costs, and maybe to give refreshments. So you cannot say a benefit of this study is a $500 phone card. That cannot be a benefit of your study, right? And remember, for clinical trials, if proven to be efficacious, will the drug or intervention be made reasonably available to the participant population post-trial? So you're in a clinical trial, the drug is found to work. It cannot be that simply at the end of the trial, the drug is stopped, and there's no idea of how it will be. Study participants may access it. We do look at confidentiality, measures to maintain confidentiality. Remember data handling, how you handle, or everything should be de-identified. And if you need to link study participant to study name, you must have a master sheet, right? Linking study participant to study name, study ID, sorry, the study ID to study participant name. And that sheet needs to be kept safely and securely separate from your questionnaires and so that if somebody comes upon it, they cannot link results to the study participant. But remember, everything needs to be de-identified. How is the data going to be stored? Right? It's going to be locked away securely in the principal investigator office in the filing cabinet to which only researchers have access. Right? So how is going to be this data destruction? Please, I invite you all to look at the UWI, not MONA now, the UWI guidelines for research, for conduct of research. The last set of guidelines are 2011. They are currently being revised, but the guidelines that we work by say that you must keep your data for 5 years post publication. Now, after that, we speak about destroying your paper, your hard copy questionnaires, etc. We do not say that you have to destroy or delete your data set, but the data set must be de-identified. But after 5 years, your questionnaires, your hard copy questionnaires, etc., should be destroyed. Data publication, data usage. So for instance, if it's a collaborative study, if it's a multi-center study and data is going to be shared, the study participant needs to know it's going to be shared. It's going to be shared in a de-identified way. And of course, you must have a material transfer agreement between the UWI and whichever other university that information is going to be shared with. Similarly, for this biomedical specimens, how are they going to be disposed of? When? Is it at the end of the study? If it's going to be for secondary use, the study participant must agree, must consent to that. If they're going to be commercial products, all of these things, the study participant must be aware of. Any adverse, what are the treatment compensation for research-related injury? It must be appropriate and timely intervention. What would be the support services, the medical, the social, etc. Non-participant participation withdrawal. So it's voluntary participant. There's a right not to participate, and there's also the right to withdraw from participation without any penalty. And this must be clearly stated. And if there are any alternatives to participation, that should be stated. Conflicts of interest, please, this must be declared from the onset. So researchers must declare any conflicts of interest. And of course, on the informed consent form, they must have contact details for the researchers, the supervisor, and a neutral third party, which is usually the chair of the research ethics committee. Please, researchers, use your UWI MONA addresses, email addresses, right? We don't want to see any fancy, email addresses, which sometimes we see. So use your UWI MONA email addresses. As we said before, comprehension must be written at the level of grade 8. And we do look at the forms and what are the threats, the language, use of technical terms, low research literacy of your participants, paternal medical culture, documentation of consent, right? So it should be written. Now, we do know we have a lot of studies now being done online, so there should be a statement online. So after they have read the consent, there should be something that says, by virtue of continuing on to answer the questionnaire, this implies consent, right? Because clearly our online consent is different from face-to-face, right? In some instances, there can be oral consent, but that has to be clearly documented. Don't forget minors between the age of 8 and 17. They need to be given the same information, but in an age-appropriate language. Parents need to sign a consent form. Even if the parents sign consent, if the minor doesn't want to do it, you cannot do it. The process should be done separately so the child does not feel pressured. And children in longitudinal studies must be consented at the age of consent. And as I said, the child decision carries all sway, not the parents. I've put case reports here quickly because usually case reports do not need, in the past, did not need to come to the Research Ethics Committee. But we have been seeing more and more where some journals have been asking the researchers, have you gotten exemption from your ethics committee? Now, the online system as it stands there you cannot upload a case report. So what we usually say is send it to the Mona Campus Research Ethics email, right? What we look at, send the actual case report that you have written and send the informed consent, because you must get informed consent now to do case reports. So from the patient or from the relatives. So you need to send that. If there are any pictures, the persons must not be able to be identified. So if you're showing a picture, the eyes or mid-face should be blocked out, etc. So if you have that need where they're asking, you send it in, somebody reviews it, and then we will say, once it's in order, we will say, yes, this is exempt from ethical review. So in conclusion, it's a common aim, research proposal and review process, right? It's a common aim. We have high quality research. Though researchers may find the review process oppressive and experience challenges, when both parties successfully work together, the result is the protection of the rights, safety, and well-being of research participants. So these are my references, and are there any questions? I will stop sharing.
Thanks, Professor Trotman. That was very clear and certainly have made the case. And yes, I've been one of those that have complained about some of the critique, but I understand now the importance of everything, whether it's a title or poor. You have definitely made the case. So.
Oh, the other thing I should say, remember now, it is a Mona Research Ethics Committee. So not all members who may be reviewing your proposal may necessarily be in the Faculty of Medical Science, because it's no longer just a Faculty of Medical Science Research Ethics Committee. So you have to write, because sometimes, as a doctor, when I'm reading it, I understand what the person is saying because I'm in the field. But the other reviewer said, I don't know what's going on here. So we have to remember that when we are writing, and in fact, that's a good thing, that somebody outside of the faculty, if you write it clearly enough, can understand what you're doing.
Okay, great. All right, so I know the attendees are, putting their questions together. So I look for a show of hands, and Mrs. Boy, maybe you can help me to identify the hands. But until I see a hand, I was just wondering where's the committee now in terms of Ministry of Health and the representative, because we do have the questions from the students. They're asking, should they wait on UA's approval before they send it to the ministry, or can both be done at the same time? Does it need to be done could you maybe give us some response on that?
Okay, so yes, it has been a long time. We are trying to get reciprocity between. We have not been able to do that. What I would say from a time point of view, that researchers should really submit, if you have to submit to both places, do it from the word go, because the processes can take long, and I would say do it from the word go. However, if you have waited, here this other thing that has happened. The researcher waits until they get UE, the Mona Campus Research Ethics approval. But then they submit the original proposal to ministry. Now, I would say to you, if you went through the whole process and you waited, and you will have gotten corrections and you will have corrected your proposal. To me, sending the corrected proposal, I've had already where the ministries contact me and say, this researcher has gotten approval, but we are now looking at it and we have concerns. And then when they say, okay, they have concerns with this, I said, these are the very concerns we had. And the researcher corrected it. So to me, send in, if you wait, send in the corrected one. But because of the time, I would say send in both of them at the same time.
Okay.
But we are working on getting that sort of reciprocity, but it has not come through as yet.
Okay, thank you. So someone, I say Abbott, and yeah, Abbott has a question. She just asked me
So,
if you could repeat the comments that you made about the researcher working in the clinical setting where they're conducting the research. I think you're saying that the research and the person who is doing the research shouldn't be the same as the clinician or in that
okay,
regard.
what I'm saying, okay, so what we have happening a lot of times is what is called one, therapeutic misconception. So if I'm the consultant in the clinic and I have a research and the patient comes to me and I add after or before dealing with the patient, I tell them about this study that I am conducting. One, it is very difficult. They don't have the agency because remember, this is a consultant who's looking after my child. And they're saying, well, if I say no, what does that mean? So they don't have the agency to say no. Two, there's undue influence. I may have managed their baby on the nursery, right? And they're saying, well, this is a consultant who managed my baby, so I will do anything for that consultant. So they are not really looking at the research, looking at the risk and benefits, and really, they're just saying, oh, Professor Trotman conducting this research, it must be good, which is not so, right? And then they're saying, well, if she's conducting this is part of treatment. So they conflate it and they get therapeutic misconception. So that is why I should not consent my own patients, right? Now, I know people ask, well, then what do we do? So what we usually say, members of the managing team may give an informational leaflet. So say another doctor, not me, but another doctor from my department is doing. I would say to them, the Department of Child Health is conducting X, Y, and Z, right? We are looking at da 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 da. This is an informational leaflet with more about the study and how, if you are interested, you can contact the researchers. Or you put up leaflets, right? You have a research assistant. So I am not approaching, it's my study, but I'm not approaching the patient. A research assistant who is not involved in care, who they don't know, that's the person who is going to approach. So why are we doing that? To prevent therapeutic misconception, to remove that undue influence, and to give the patient the agency to say, I don't want to be in this study, and I know it will not affect my care.
Yeah,
So I don't know if I've answered the question.
yeah, I can appreciate that, Prof. I mean, sometimes, depending on how, the nature of the situation, the patient may actually think that, well, if I don't consent, I'm not going to get
Exactly.
what I
Mhm,
need, and
mhm,
yeah,
mhm.
and feeling
That's
that,
why consenting a patient the morning of an operation, we do not allow that
mm,
because I am there waiting to go in and somebody's consenting me. I'm going to say yes because you want to put me to sleep and I don't know what's going to happen. I'm going to say yes.
that's
No,
true,
let me
that's
tell you something. We do recognize that in certain situations, we still have to do research. So, for instance, the emergency department, right? We recognize that you still have to do research. So we do look at that, because somebody who comes in, but clearly somebody who comes in with an MI, you can't be consenting them, right? Because they are not. So we recognize that they are that, and we will look and we will work with researchers. That's the only thing I wanted to say. If we have sent a comment to you and you think that, okay, if we follow this comment, we can't get the research done or whatever, reach out, right? It is not that if we give this comment, it has to be so.
true.
So reach out to us and say, listen, we have seen this comment, but if we don't do so and so, whatever, whatever, and we will weigh, we can't come to. So that's the other thing. Researchers, feel free to reach out if there's a comment that you may think would unfairly prevent you from being able to do your research, etc.
Okay, thank you. So I have a question in terms of who can be PI. And the specific question, principal investigator,
Mhm.
is should it be the student or should it be the supervisor? What would you
The
recommend?
problem with PI, particularly if we are dealing with human participants, is that the students cannot take responsibility for, say we're doing a patients, say we're doing it in a hospital, and it's, you know, a postgrad student, a medical student. The medical student cannot take responsibility for those patients. So in that case, the PI has to be the supervisor, the consultant, or whoever who's employed, because the medical student is not employed to the hospital or whatever. However, being the PI does not mean that you have to be the first author. If this is student work and the student has done all the work, right, and a paper is coming from it, then the person who has done that work, and I mean, these things need to be discussed at the beginning. The student is the first author, right? Although I'm the PI, because I am taking responsibility for the study participants, if there's a publication and it is a student's work and they have done the work and they meet the requirements for authorship, they are the first author.
Are you saying the DM students who are working at the hospital cannot be PI? I mean,
not from a research point of view, no, they cannot take responsibility for study participants and if, you know, something happens, etc.
Okay. All right, I know you weren't addressing clinical trials, but I had a question on clinical trials, and I haven't seen anything, any hands up. Clinical trials in terms of what would you need in terms of the actual agent? If it's a drug, what is it that the ethics committee requires?
So this is a new interventional drug, okay, there are two things. You can have a drug that is totally new, it's now being developed, or you can have a drug that's already in use and approved for use, but you are going to use it off, what do you call it? Oh,
off-label use. Off-label use.
Right.
Yeah.
So there are two different things. Now, any drug and even off-label use, you must get permission from the Ministry of Health. I'm trying to remember the name of the it's standards and
standards and regulation department.
Right. So first of all, before you even send that proposal to us, so if we get a proposal and it's a drug, the first thing we say, send the that what you have gotten approval, send a copy of the approval. So we are not even going to look at your proposal unless the Ministry of Health has given approval for that drug to be used, and you know, in what age group, etc. Now, even the off-label use, because I spoke with the Ministry of Health, even off-label use, you must get approval from the Ministry of Health. Okay. I'm not going to look at that clinical trial unless you say to us or you show us that you have gotten approval of that drug.
Okay. And if it's a new drug?
The same thing. It has to first, they do still have to go to ministry now, because remember, even to bring it into the country,
okay,
they will have to have the relevant approvals.
What if it's something that was created here?
Okay.
Drug here, like, I mean, I know there are some.
I understand.
There's like some of the cannabis agents that people have purported as drugs that are being made by pharmacists in the country.
Well, for us, again, we also ask, you know, whether they have gotten approval from the ministry. We do, but I can understand what you're saying with something that is developed here. But we still have to know whether, even if we gave ethical approval for this study, they still have to get permission from the Ministry of Health. Okay.
All right. I'm not seeing any questions. I look like I'm the only one who is fielding questions. Helen, so I think this is probably yes.
No, what I was saying, it's one of two things. Either it's crystal clear, or it's murky.
It was.
Crystal clear.
It was. So I'll just ask one last question.
Somebody has her hand up though. Jennifer Knight.
Sandra, tell me who it is.
Dr. Knight Madden.
Oh,
yeah, Professor Knight Madden, please go ahead.
to help me with those last questions? Is it that?
Yeah. Oh,
Yeah,
yes.
one of the things with the DM students is that they do their projects, they want to do their projects and then submit them and go to exams, and then they're gone to start their job. And the research project was just something that they did in fulfillment.
Yeah,
But
yeah.
there can be, part of the reason for doing research is generalizable knowledge. And
Right.
many people are going to read your DM project. So the PI is somebody who has a long-term contract, long-term employment, and can see the process through to its proper end, which should be at least an abstract, if not a paper. And also the DM students should be happy that they're not the PI, because the buck stops with the PI. If
That's
there's
it.
a problem, somebody complains, whatever, even if the PI is not there. Just as how the consultant might not be in theater, but there's a problem with the surgery, the
And
book
it
stops
works
with
up
him
with
or her. It's the same thing with the PI. That's the person who takes responsibility.
Okay. Thank you so much for that.
Thank you.
All right. So last thing, and then I know you have to go because you have another very important function a little bit. A little bit about retroactive approvals. You know, I've done something in my lectures, and I've done it for the past 5 years with the students. And based on how the students perform, I think this is nice data to report. You know, some medical education journal might be interested in my methodology. But it's not something that I really requested ethics for. I mean, can I still apply for ethics for that? I mean, I have the data sitting there, as I said, I didn't think about
So,
being able to
okay,
publish
what
it.
I would say, okay, and we have that happen a lot of times. I'm not doing research, but you may have developed an innovative way of teaching something, and then you realize, but this other people can benefit from reading it. No, I don't know that is retroactive, and Jennifer can come in and help me. I do not know that is retroactive approval, because this was something that you were doing as part of your teaching. And now you have data and you say, I now want to look at this to see, is this method of my teaching, what is the outcome? Is it beneficial or whatever? So if you send that to the ethics, I don't view that as retroactive. What I view as retroactive is that you started out, you knew you were doing research. This was research from the word go. You are doing research and you didn't seek ethical approval. And now that you go to publish it, they're asking, have you had ethical approval? And you're coming now for retroactive. I don't know, Jennifer, can you help me there?
Sorry,
Professor Nightman.
some things, sorry, I was struggling to unmute. Some things in education, depending on what it is, may
Right, it's
be
exempt.
exempt. So you really have to look at what exactly it is, if it's like a
Right.
method or so on. But the basic thing is, if you always go back to the basic tenets of research ethics. So is a person being given their full autonomy? If you are talking about the method and the individual is not that important, where if it was your child in that class, you wouldn't mind if they publish that data, because the individual is not exposed, then sure. But the best thing to do is, if you think it's exempt, or you think it, is to submit it.
To get the
You will
exemption.
find people that, when you get a proposal that's dated, you get it today, and it's dated in February 2024, and it says it's going to start in April 2024, and you're getting it in March of 2025. That's clearly a problem.
Okay, thanks for that, Professor Nightman. And in fact, the next question in the chat actually relates a little bit to the exemption. Catherine is asking, how does a researcher submit to ethics for an exemption? Let's say, well, she's specifically referring to mosquito study, so it does involve humans, but I guess wherever she's going to publish it, they would like to have some evidence of
Well,
evolution.
we do have a subcommittee that deals with approval of for animal studies. I don't want to, there is on the online system, there's somewhere to submit if you think it is exempt, and we will look, or simply make contact with the ethics committee and say, I have this, I'm doing this. Is it exempt or not? I've had people do that, and I say, give me more information, whatever, and then we are able to guide them. To guide them.
Thank you. And next question, does one need ethical approval for secondary data or meta-analysis?
Okay, this, usually with even secondary data, we say, yes, send it in, let us see, because it all depends on what this secondary data is. So for instance, data that has been collected in the hospital, in patient files or whatever, while that may be secondary data, but you still do need the ethics committee to give you approval. I think things like, there may be some data sets that are in the public domain. I don't know about that. Again, Prof. Knight-Madden can help me here. But generally with secondary data that is dealing with human participants, we still say it needs to be submitted.
I mean,
So the next
you
question,
do have data repositories that have de-identified data. I mean, the NIH is trying, it's hard to get a grant from them unless you're gonna make your data available for others to analyze it. But even when it's in a repository, unless it's like de-identified and there's absolutely no risk to the person, then you may be able to just go on the repository and use the data. And in fact, that's an issue for us in Jamaica, because sometimes if you upload your data early to a repository like that, somebody else might publish the paper before you get around to it because of your other duties. But even for repositories, once there's anything that is that needs some thought, what they will say is send your proposal with your ethics approval, and then you get our data. So, even for secondary analysis, sometimes you can't get the data without ethical approval.
Just to add though, because I think that it was a two-part question, the systematic review. So now this is going to the literature, and these are studies that are published, and you are pulling that data and doing a meta-analysis. Those do not need to come to the ethics committee.
okay. All right, so this one, I think you went through it actually, but I guess just a little more reinforcement. You're doing a retrospective study, so you go into the data, but when you start going through it, you realize, the patient's age is missing. The patient's concomitant diseases are missing. Boy, I need to give this patient a call and see if I can collect the data. Let's respond to that one, please.
Very easy response. No. Because remember, with retrospective docket reviews, the ethics committee takes on the responsibility of giving consent for you to go to those dockets. And we give consent for you to go for specific things, right? And that it's going to be de-identified, because we recognize if you're looking at patients over 5 years, to find those patients, to be able to consent them, etc. So it must be a minimal risk study, right? And the ethics committee, it's not that you haven't gotten consent, it's the ethics committee has taken the responsibility for giving consent. So for you now, and the reason we do that is that there's going to be no contact with the study participant. That's what a docket review is. No contact with study participant. If you're going to go to the docket, take the number and call the patient. That is not acceptable. And in fact, and I keep on saying, because we are waiting for, because as you know, the Data Protection Act, we have always have these protections, but with this new Data Protection Act, it is even more so. The hospital is at risk. If you do something like that, the patient can, go to the data protection
Agency.
Right, and file a complaint against the hospital, and the
Yeah.
hospital is liable.
Right. So, Prof, we'll make this the last question. I see it's 4:16. We need to give you a little break, even for a cat
Yes,
nap.
that's a go.
So Tanya, Dr. Ricketts' room, you have a question, but I'm not sure exactly what you're asking. I don't know if you want to open your mic and you're trying to figure out how to extract patient data. Dr. Ricketts' rooms?
Yes.
Yeah, maybe you could just
Right. So in a situation where, for instance, you're looking at, said a docket audit or a medical record audit, and you, in other words, how would you be able to extract the data from those dockets? So, for instance, you're looking at persons who had were treated for asthma or any other condition over a particular period of time, and looking at how they were managed. Suppose you're looking at number of HbA1c tests that were done, have they been doing them, etc. Yes, you don't want to interview the patients because that's not how the study is constructed. How would you then be able to access information from those files ethically?
I'm a little lost.
So
What
if you,
mean?
so in other words, you don't work at the facility, you're
Oh,
doing
you
research
don't
in several
work at the
facilities in which
facility.
you don't work. Even if you work there, I heard what you said, that as a clinician versus as a researcher, there are different boundaries that you have to respect. But suppose you're doing it, for instance, in the health centers in Kingston and St. Andrew, and you want to look at how well they're adhering to an international guidelines. And you just really need to see whether or not the doctor has recorded in the file or has even requested these tests every 3 months, every 6 months, whatever it is. How would you go about getting that information? In other words, because if you get access to the files, you're knowing about patients that you never have permission to know about. You understand what I'm saying?
Oh,
So,
so what you are saying is, how are you going to determine which dockets belong to patients who is under your study? I'm trying to.
So in other
So
words, you're not managing the patient.
no,
You
it's
just
like
want
an audit.
information about how, right, like an audit.
It's an audit, but the issue is that it's not her patients.
Right.
Okay, because if, say, I decide I want to know, is hydroxyurea being offered in the sickle cell unit, because I then want to sit down with my doctors, with Dr. King's doctors, and say, guys, we're only offering hydroxyurea 20% of the time. We should be offering more. That's an audit internally to try to improve processes.
Right.
It's not research. You're not trying to do something for generalizable improvement of knowledge. That's an audit. But what if you know what you're saying is that your
You're not part
research
of that
project
health.
is now to audit somebody else, and you wouldn't necessarily have access to those data, then that becomes a thing.
Well, that becomes a problem, because ideally what should happen is that the institution should be able to give you de-identified data. But we do know that in reality, so what should happen is that you're supposed to be able to go to those clinics and say, okay, can you supply me with this data? So ideally that's what should be, because then you're only getting data pertinent to your research. We know we don't have that sort of infrastructure. So what you're asking is difficult, because I mean, I truly do not have the answer for that, because what really should happen is the clinic should give you the identified data. They should be able to pull it down. Of course, we don't even have electronic.
I was about to say, it's
I know we
easier
don't
when
have
you have
mechanisms of that.
EHR. You
So
can't just
that
punch in what
becomes,
you're searching for. Exactly. When you have
really becomes
paper-based files, how do you get that
yeah,
information?
yeah. It's problematic when you're not part of that healthcare system.
Yeah, okay. Thank you.
Yeah, so thank you very much, Prof. And Prof. Trotman. Is there an email address? I mean,
for the
follow-up questions, email address for the
sure, man, it's MCREC, so Mona Campus Research Ethics Committee, MCREC at uwimona.edu.jm.
Okay, thank you very much. So Prof. Trotman, it was really very informative and very well presented. You made your case. I don't think anybody will object to any comments you made today.
Hopefully not.
And I'm really glad that you were able to make this time. Really appreciate that. And I'm looking
And I do
forward to
want to re-emphasize the researchers that we are not the big bad wolf. Reach out, send an email, we will respond. Right? I can't promise you I'll respond 5 minutes after you send it, but we will respond. And sometimes we do have discussions with researchers. But one thing I would say, please try your best to do all those internal checks and balances at the department level. Because you see, when you do it at the department level, you can do the fix right away and get back. Just to give you an idea of the process, when you come to the full committee, and so remember, it's about a month before you have to submit. It comes to the full committee, and then we have these comments. If the comments are extensive, and if there are flaws, then it has to come back to full committee. If the comments are something that can be dealt with quickly, it's not a methodological flaw or whatever, when that comes back, it goes to the researchers. It doesn't have to wait until the next. And that's what you want to sort of not have happening, that each time you're coming back to full committee. So I am begging, because it makes a difference, do those internal checks. Supervisors go over. And there's one other thing that I'm going to say, because some persons say, oh, all they're doing is correcting English, right? No, you know what? English is a supervisor problem, It is not the chair's problem. But guess what? If what you have written I can't understand, then it becomes a problem. How am I going to review if I'm there saying, well, what does this really mean? So again, there's supposed to be internal checks. There's a spell check. There's a spell check, guys. Spell check, grammar. Don't make the committee tell you, please edit for grammar. No.
Yes, and remember, you're also representing the University of the West Indies.
Exactly.
So you can't be sending out a consent form that has, really bad spelling and grammar and everything. No, because it's not just yourself that you're representing.
Exactly. So the consent form, we do not. Sometimes in the other parts, I say, you know what, this is supervisor, but I'm not saying that for the consent form. It's a contract.
All right. Well, thanks. And I see the positive comments being put in the chat. Thank you. It was very informative sessions, very clear. I endorse Prof. Trotman. Prof. Trotman called me personally after submitting a proposal. This was a case report, etc., etc. So they are very, very appreciative of your receptiveness to reaching out and facilitating the process. So thanks again. I do realize as Deputy Dean that a number of the departments have actually taken on the direction that you have recommended, where they are reviewing
internal
before they get. So as I will ask, if there's any department that you think there's a challenge, you could just reach out to me as well, so I can probably recommend these kind of changes. But thank you very much, and I'll see you again in a little while.
Yes. And thanks for inviting me.
Yes, and thanks attendees. We went up to about 60. So we had good representation, and I saw persons from most departments. So I think they will be willing to share the information.
Okay, thank you.
Yeah, bye-bye.
Bye.